All right, guys, can you hear me okay? All right, awesome. So let's get started. This is, for those who were here last year, this is a very similar talk to what I gave last year. I've modified it a lot. So there are, I think last year there was probably 110 slides, maybe around there. There's 224 now. We are not going to go through all those today, obviously. It's going to be probably split up into 3 sections. But the reason why it's so long is because I really wanted to include everything that I could imagine that would be beneficial, not only for you as a general internist, but things that you're going to be needing to know for your boards. This is not going to be for obviously the cardiology level fellows, et cetera, but I think it's going to have a lot of common findings that are not necessarily common, but things that you should know about because they may affect your overall medical management. So we're going to go basically, again, how to approach the EKG. And again, this is going to be divided into multiple sections just because of how long it is. I'm not expecting you guys to be masters. I'm not. I think part of the reason, just like last week when I did the talk on hypercalcemia, that I wanted to do this talk was because it just helps me get better personally. And I recommend you guys do that for future purposes too, because if you kind of focus on just topics that you're good at or you're interested in, it's not going to help expand your understanding, right? So try and branch out into those areas that you might not feel comfortable with. I know that we have asked you guys to do some lectures as residents and you got to kind of pick what areas you wanted to. So hopefully you picked ones that you're not necessarily comfortable with to help you get better. But we're going to go over the basic principles, really how to do acute and chronic issues. And then I'm going to go over a lot of time. Pretty much most of today is going to be going over like the physiology and anatomy of this, because if you've rounded with me, we've gone over EKGs, you know that if you understand that, especially like understanding access and the anatomy for occlusions and where you'll see it on the EKG, it's going to be less memorization and then more applying the understanding of something. So then you can do a better job of coming up with an understanding or differential diagnosis of why I think something's happening, because it would make sense from a physiologic standpoint. And then the last thing, obviously, how to spot AFibs. It's the most common arrhythmia that we see, as mentioned in Dr. Griggs' talk last Monday. But it's also something they're going to really want to make sure you know, just on not just for ACLS, but for your boards. So we'll go over, I'm not going to try and ask, I think on the previous slide, I'm not going to ask you guys to interpret the EKG in front of everyone for an entire thing, but if there's pathognomonic findings or obvious, I don't want to say obvious, but like major findings, I will ask you guys to do that, because I think it is important not only to just feel comfortable, going over this in front of your colleagues, knowing that this is not an atmosphere where we're going to judge, but just so you feel comfortable putting on the spot, because when it comes to codes and other situations, you will be put on the spot. And if you can get past that kind of mind fogginess or brain fog that happens typically when we're nervous, then it's going to help you become better, not only for presentations in general, but when you're put in dangerous situations with patients. But these common EKG findings that I put at the bottom, they're going to be talked about towards the end. So probably in the third lecture series. There's a lot, just like on every single PowerPoint I go over, there's a lot of information. I'm not going to read slide by or line by line. That's not the point of a presentation nor a PowerPoint. But it is important. I'm going to focus on the things I want you to get out of it for each slide to make it easier for the interns who weren't here last year. You'll see that there's a handout. Jody said she sent it again just now. And I also attached it to the chat box. So you should be able to open it up and save it. So use that handout to follow along. If you print it out, it's meant so that the EKG will be on one side and then the opposite side that's covered would be the answer. So you can kind of quiz yourself. But at the bottom of all the this PowerPoint for the relevant slides, I'll have kind of a legend so you kind of see where we are in the overall rhythm strip as well as the PQRS complex. So we'll go over the first topic is really what probably is going to take up the most of today. Maybe we'll get into the anatomy as well. Then we'll go over the systematic approach once we understand that understanding of it. Then we'll do some common arrhythmias, those conditions like WPW that I mentioned earlier, and then things that you might find from a benign setting in African Americans specifically, because I don't think that's really going to be coming up from a board relevant standpoint, but it's going to be obviously clinically relevant. And then EKG changes that we'll see with electrolytes, because that is something that we see almost daily, in the inpatient setting. So here's a systematic approach that we'll get to probably on the second part of this lecture, but I'm not going to just read all these slides, or these numbers, but you can see that for the most part, it is somewhat alphabetical. This is very important, just like my chest x-ray talk, making sure you have a systematic approach and not skipping just to the ST segment. This was brought up in the M&M on Monday. If everyone skips just the ST segment, you might have missed that the person was in complete heart block versus second degree type 2, right? So make sure you go through the systematic approach so that you don't miss something that actually might be more dangerous to the patient. I kept this in from last year just to understand why we say ECG versus EKG. It's just basically the cardiac or the Greek translation of it. And then the reason why we do PQRST rather than just starting from A through E. And it's really because when they were initially developing the EKG, there was a lot of friction that was generated by the leads themselves. So when they corrected the findings for the actual friction that we saw, they used the letters PQRST, and that kind of stuck. So before we begin, we're going to go over how this ECG is actually generated, the anatomy and physiology behind it. And then I'm going to go into the two major types and just knowing, the two types of limbs. You have your limb leads and then your precordial V1 through 6. It's really important to know where these are placed anatomically on the patient themselves, because again, that's going to help you decide where do you think the pathology is. Is it that an LVH is on the left side of the heart? Is this the circumflex that potentially is involved? Or is it the RCA because I'm seeing it more on the V1, V2 side? And then you have your augmented leads, which are generated by the machine itself and that's going to help mostly not just for identification of where elevation or ST elevation and infarction might be, but when you're trying to decipher the axis for someone, it's going to be important to know the augmented leads as well as the limb leads specifically. The precordial don't really play a factor when we're doing the axis generation. When you start with the ECG lead sheet itself and interpretation, just know that let's go over some basic understandings, because the time that this is going to come into factor is when you are deciding if there's a block prolongation. So you need to know the duration of these boxes, the big box versus the small, the big being 5 millimeters or 0.2 seconds. And then the small boxes being 1 millimeter. So 5 small boxes will lead to 1 big box. And then as a result, if you divide 0.2 by 5, then you're going to get 0.04 seconds. So you don't have to, I guess, never necessarily memorize all that. If you were to be able to memorize that 1 big box is 5 millimeters, which equals 0.2 seconds, then you should be able to just count out then the small ones and then do the math yourself. But, I think if you do it enough times, you'll end up memorizing it. And then knowing that the speed itself is 25 millimeters per second, I think it's important to know that, but you shouldn't have to memorize that. There should be no reason why your ECG tech or the person that's obtaining it should ever change that. But the things that they can change are going to be our calibration box. And again, if you've been on rounds with me and been when we've gone over it, the first thing I tell you to do on top of looking to make sure it's the right patient and then knowing the date of this ECG, so you're not looking at one from yesterday accidentally, is to know that that calibration box is there. And that is something that can be changed. Typically, it's going to be incidentally by an ECG tech. But if you have a very high calibration box, then you can make it look as though someone has left ventricular or right ventricular hypertrophy versus if you put someone or you decrease that box from two large boxes, I should say, to like 1 large box, then everyone will look like they have low voltage. We had a patient last week who had a pericardial effusion without tamponade physiology. And that was one of the things that I told the team that I first looked at, on top was the calibration box. And I wanted to see if this patient met low voltage criteria, and they did. So that's kind of interesting being able to apply it clinically to someone. Oh, and then I should say to too small, it's not just going to be for effusions, but if someone has obesity or COPD where you're going to have a lot of distance, that's going to diminish the ability of those leads or electrodes to sense the electricity. Just think it's more distance or material, whether it's fat, for that electricity to travel through, then it can appear to be low voltage as well. For the placement, this is where I was telling you that it's important to know from an anatomical perspective because it's going to affect our ability to know where infarctions or ischemia might be happening. And then we can relay that to the cardiologist if we're calling them overnight, for example. And then we can even see based on like maybe their blood pressure, if it's low and we're thinking this is the right ventricular infarction, does it make sense based on where we're seeing on V1 through 2 versus V4 through 5. This is something that you should commit to memory. The V1 through 2 is really going to be your sternal axis. And if you're trying to apply it yourself, and I do recommend for any level, I'm not going to say just for interns, because I think there's plenty of probably second years or even third years who haven't had a chance to put these on themselves because we just have so much assistance in the hospital doing that. But if you're able to try and do it yourself just to get a better understanding from an anatomic perspective, just find that angle of Louis, which is going to be kind of right around here, that initial notch that kind of depresses next to the thyroid region. And then you're going to go down 2 intercostal spaces and you'll find the region where you should be putting the 4th intercostal space of V1 and 2. And then from, honestly, for the V3 and 4, it's kind of estimated because for the most part, most people will jump to V6 because that's the mid-axillary line. So then they'll find that after they find V1 and 2, and then 3, 4, and 5 are kind of somewhat intermixed between the two, to be completely honest with you. Some techs will actually measure it out, but for the most part, we'll do V1 and 2, then we'll find V6 because we have clear anatomic marks for those, and then we'll just mix or play the V3 for 5. The AVR is going to be kind of in the right extremity, AVL is going to be the left extremity, and then AVF, which is, foot, will be on one of the hips for the most part. What do you need to remember? Something as simple as the idea of where depolarization is starting and where it's ending is going to help you truly understand why these leads generate what they do. So what I mean by that is that if you know that the SA node is going to be in the region of the superior portion of the right atrium into the vena cava region, and then it's going to be moving downward in a downward left position towards the AV node into like basically the left ventricle, then you know that the electricity, if we had AVR here, if it's moving away from that, it should create a negative depolarization, correct? Let me see if I can turn on my drawings again. So yeah, you should see a negative, oh, it's not going to let me draw on this for some reason. Let me see if I can try it again. Oh, okay. Well, it's not going to let me draw. So you should see a negative depolarization. Whereas if you're in lead 2 and it's down here in the bottom left, and I'll have another slide that kind of helps visualize that, and it's seeing this electrical depolarization come downward, then you should expect that that should be a positively because it's coming, the electrical axis is coming towards it. This seems very archaic and basic, but it's really, I don't assume that everyone knows that. And I want to start with that because it's going to help understand everything from this point forward. And then again, lead AVL is going to be somewhat perpendicular to that. So you should see more of an isoelectric line, not a purely positive line. And then lead 1 is going to be somewhat perpendicular, but not really. So then you should expect to see more of a positive than a negative deflection. So to explain that again, though, if the wave of depolarization is coming from the right side to the left side, you're going to see it purely positive. And then if it's going from right to left, but that lead is on the left side and it's going away from it, then you should see it purely negative. If it's perpendicular to the electrical activity, then you're going to see this isoelectric. And then you can make the inferences based on if it's a little off of perpendicular, more towards positive, more towards negative. So again, something as simple as that will help you understand when you're looking at the EKG, where does it seem like this depolarization is happening? And why do we think that's happening? Is it because there is LVH happening? So it's attracting more of that positive or that activity? Is there an infarct that's caught? Maybe it's at a bundle branch that's requiring the electrical activity to go around a diseased area that's creating now not necessarily a purely positive, but more of an isoelectric. Again, those things we'll go over, but it'll help you understand it more. Basics of the EKG appearance. Most of you already know this. We already just talked about the big box, 5 little boxes, 0.2 seconds with each interspaced box being 0.04. Depolarization, as we know, is contraction of the muscle. The P wave is going to be your left atrial depolarization, with repolarization happening right around the Q to R region, with the QRS being depolarization of the ventricle, and then repolarization being on T, which is why, as Dr. Gray talked about, when you have someone, if you don't put the synchronization on for a synchronized cardioversion and you get that R on T phenomenon right on the repolarization, you can put someone in VFib. I don't know if they still use this on the boards, but the common one, and I've read about it, not seen it, but I read about it, is where you have a catcher in baseball and they happen to take a fastball directly to their chest. And if it happens enough, which is basically like just doing a large compression for like ACLS onto that T, it could reproduce that as well. So I'm not going to go over this slide on the right side, but you can just see everything I just mentioned, the atrial depolarization, the delay in the AV node, and then how it kind of progresses over. And then again, knowing this is going to help you understand where the physiology or where the pathophysiology is happening, as well as potentially where QR or electrolyte abnormalities are happening too. I don't know why. Oh, okay. I forgot that I put the animation there. Actually came out pretty good. I tried to draw it myself. So you can see that that blue, the depolarization, and then the repolarization is going to happen with the yellow. So what are the basics? I'm not going to go through this slide. This is a slide that I think appears in every book and everything, and just understanding the atrial muscle and how it affects that overall EKG lead. But I think this is a very advanced, unnecessary advanced slide for our level. But just knowing that when we have that SA node here, and then it's going down to the AV node, from that point on, it's going to go to the common bundle, and then the bundle branches through the Purkinje fibers that allow it to lead to ventricular depolarization and then contraction of left ventricles. So when you see these bundle branches and there's a bundle branch block, then the idea, which we'll get to more in the bundle branch block section, yes, commotocordis, absolutely, Dr. Greg, is that term. Is then when you have a block here, then basically electrical activity has to go to the right side if there's a block on the left, and then it's going to have to use other fibers to kind of eventually get that left side, which is what's going to create that prolongation. So what are the basic components? You have your waves, you have your segments, and your intervals. Why do I mention this? Because again, when you're going through the systematic approach, it's very easy for us to just jump and skip past PR, QRS, and all these intervals and segments. So it's important to make sure you address every single one of these, because there is unique pathology that might happen to each one of them. So that PR interval, it's going to represent the PR or AV conduction. We should look for that to be less than 0.2 seconds. So one big box. If it's prolonged consistently, as talked about the lecture by Dr. Greg on Monday, then it's going to be a first degree. If we see that, consistent prolongation with eventual drop, that's that Wickenbach. That's going to be your secondary type 1. We'll get to that again. If it's short, you can think that maybe this is a junctional rhythm. Potentially, they might have even a P wave, or the P wave might be inverted with that junctional rhythm. Whereas if you have a QRS, it's going to represent the ventricular depolarization, as we mentioned. It should be at least, ideally, less than 0.12 seconds. 0.15 is where it's going to be truly prolonged, and somewhere in between will be intraventricular conduction delay. And then your QT intervals, we think this more about the QTC with our prolongation in patients that are maybe on taking a medication. Can you guys list some medications that classically will prolong their QT interval?
Azithromycin.
Yep, azithro. Yeah, macrolides. What about your patients that have chemo and very nauseous? There you go, Zofran antiemetics, absolutely. So just know about those ones that can cause that QT prolongation. It should be, if you want to do a very rough estimate, I've told the team this on rounds, you can use this 1/2 R to R. That's definitely not absolute. Okay. So don't use that. Oh, this is not 1/2, then it's not QT prolongation. If you're very quickly looking at it, maybe it's, if you're doing EMS or something like that, and you don't have necessarily the QTC that's calculated for you on your rhythm strip, then you could use that as an idea. If it's anywhere even near half, you should automatically, be concerned that this is going to be something that's prolonged. These patients are going to be at high risk for torsades. You can probably watch their magnesium level, make sure they're on repletion for it. I think this was discussed last week as well, but we're going to talk about that more later. When it comes to leads, we talked about this. AVR, know that it's going to be on the right limb, the right shoulder. So like electrical activity should be going away from it. So AVR should be overall a negative deflection. AVL on your left limb is going to be more isoelectric to the most part because the electrical activity is kind of going towards it, but perpendicular in a way. AVF, depending on where they put it, is also going to be somewhat isoelectric as well. These are augmented because they're just measuring the flow from the center of the heart. They're not theoretically like true leads. If we were to look at how the leads would be placed or how they would look on someone in comparison to a cardiac MRI, this helps you see where the electrical activity is truly being measured. So if you had V1 on that right sternal border, like I mentioned, on the fourth intercostal space, and then you had V2 on the left intercostal space, the fourth border, and then we said V6 was more on the axillary line, you can see how this is the left ventricle because of how thick that ventricular wall appears, that how allows us. You can see that the right side of the heart is truly what is seen for the most part by V1 through 3. V1 through 2, remember, is more of like the sternum. So if we're thinking about infarctions or areas of infarct, we're thinking about that with like the LAD or so. And then V4, 5, and 6, you can see that that's capturing maybe some pathology on the left side of the heart. So then we're thinking more like left circumflex or true left ventricular isolated involvement. This is definitely not absolute. It's just, I thought this slide, I want to put this slide in because I thought it was a good way of just being able to visualize how the heart truly appears on the chest x-rays, cardiac MRIs, whereas most people, I think non-medical would be like, oh, I always thought that the left side was, on the front. Like, no, it's actually completely rotated right. So we see the right side towards the anterior portion of the chest. And those standard limb leads, the 1 through 3, are going to be generated. So they're not based on any placement because your EKG tech, your nurse is going to be putting the augmented leads on. But the limb leads 1 through 3 are going to be generated. So no, this is going to happen or be important when we're deciding or being able to determine our axis. That lead 1 is going to be pretty much straight on at 0. Lead 2 is going to be at 60. And why do I mention that? Because we know that at about 30 degrees, we find out that with axis generation, there's a potential that someone could have a normal axis from 0 to 30 or so. So that's why when you're using just the 1 in AVF as your quick marker of, is this a left or right axis deviation? Theoretically, if the left axis deviation, there could be potential that this is truly a normal axis if it shows up in that 0 to 30, which is why we like to use the lead 2 and lead 1 to help us out. I'm going to get to that in a second. I don't expect you to even understand what I just explained, but I'm mentioning this because I want you to know that there's a reason why we're going to go through each one of these very in depth. And then lead 3 is going to be more at 120. So again, we expect that electrical activity is probably going to be somewhat isoelectric, if not a little more on the negative side. If we look at the augmented leads, AVL is going to be at -30. This is where I kind of talked about how you can, man, I really wish, I don't know why it's not letting me draw. Let me try. Maybe I'll try here. I'll try it with Zoom. So when we're doing our lead generation, we're going to have our axis generation. We're going to make that circle, right? And what I'm talking about is this area right between here is where we can get fooled, or we think someone has left axis deviation, but they really don't. So leads AVL are going to help us kind of generate that, as well as lead 1, because lead 1 is going to be kind of right around here, and then 2 is going to be just a little below, etc. So we'll get to all that. Keeps my, let me clear all that stuff. Okay. So if we are putting all this information together, you'll see is lead 1 is going to be right here at 0. Lead 2 is going to be at +60. Lead 3 is going to be at +120. AVR is going to be directly to the right side. You don't have to know these degrees. AVL is kind of important because of that -30 number, which we'll get to when it comes to axis generation and determination. And then lead 2, between leads 2 and then +30, you're going to see that's like the overall generation of electrical activity. So if you look at the bottom, you see that, excuse me, normal activity is moving to the right upper part of the heart, where that SA node should be, through the AV node down to the bottom left of the heart. So we expect that, again, lead 2 should be overall positive deflection. Lead 3 and AVL are somewhat isoelectric, so they're going to be, because they're almost perpendicular to this overall line. Lead 1 is not going to be as perpendicular, right? We'd expect this to be more negative or more positive. What do you guys think? Yeah, absolutely positive. And then AVR, we'd expect that to be positive or negative. Anyone? Negative, yep. So again, I'm going through all this basics. I guarantee you that it's going to make it a lot more understandable. So again, the placement, just as we talked about, because I didn't want to just put this right after the previous slide, because it's not really testing your memory. But you can see that V1 and 2 are at that fourth intercostal space, 2 spaces below the angle of blue, which is right around here. And I said V6 was at the axillary region, and then 3 through 5 are kind of anywhere between. So if we were to look at AVR from the upper right portion, we'd expect that to be in negative deflection. If we look at AVL, which is pretty much up here, it's kind of somewhat isoelectric. Down here would be AVF, and we can see that that's going to be, again, somewhat isoelectric, maybe a little negative. Here would be lead 1, so the electrical activity is kind of coming towards it. Lead 2, it's purely positive for the most part. And then lead 3, it's somewhat isoelectric as well. So this is a slide that I told you I'd come back to so you can kind of see what the lead is basically seeing. This is what this slide represents. What would if you were to focus just on AVL and it's trying to read this electrical activity, what is it seeing on its own? It's seeing the activity kind of going isoelectric towards it or perpendicular. Well, why don't we try and correlate and put all this together into an anatomic perspective so we can then, I guess, put it into terms of true infarct with the EKG. So if the anterior wall is on this region, that's mainly like the LAD, then we'd see that that truly could be anywhere V1 through 6. You know, V1 would be here, 2, and then 3 through 6 would be around here. It can be any of them because it's going to affect the bundle branches too. Whereas the posterior wall can be, you know, the RCA as well. Sometimes you can see some the LAD kind of looping under the inferior apex region of the heart, but for the most part, we'll just assume right now it's going to be the RCA. And that's going to be also, you could get some of the circumflex as well, but that's going to be V1 through 2. You'll see some ST depressions there. The lateral wall is going to be your circumflex primarily. That's going to be 1 in AVL. That should make sense because AVL is on the left side of that arm. And then V5 through 6, we said, is more in the axillary region. And then inferior wall is going to be, again, like I said, that you could get some part of the RCA that goes all the way down, or you could get a distal portion of the LAD that wraps under it. But that's a smaller percentage. For the most part, people are RCA dominant. And that's going to affect the SA and the AV nodes. And I think this was brought up on that M&M last week. The idea that if there is RCA involvement, then you can see someone go into a complete heart block as a result. And we know that the 2, 3, and AVF, for the most part, are going to be our inferior wall anatomy. So if we were to correlate this with the anatomy, you can see again, one is going to be, the lateral leads will be 1 in AVL. That's called like the high lateral. The low lateral is considered V5 and 6. So if you think there's lateral involvement in general, then you'd expect to see some kind of pathology in 1 in AVL as well as V5 through 6, whether it's ST elevation in V5 and 6 with depressions in 1 in AVL and vice versa. For the most part, the anterior, like I said, can theoretically affect all of the V1 through 6, but if you want to just be very specific, you could say V3 and 4 specifically. The septal, as we mentioned, V1 and 2 are at those fourth intercostal spaces, so we expect that to be more V1 and 2. And then if there's inferior wall involvement, for the most part, if it's RCA, then it's going to be 2, 3, and AVF. And then you could see some reciprocal depressions potentially in any one of the V leads or precordial leads. So I'm going to skip that slide because, again, it's just showing overall. The only thing I'd made different was I put that the lateral side was here and then the inferior side is here. So you can kind of see why certain leads would be affected, whether it's 2, 3 AVF on the inferior side, whereas if it's the lateral side, it's going to be 1 AVL and maybe even V5 and 6. Any questions so far before I go to the systematic approach? All right, I'll take that as a no. So let's go through the systematic approach. So rate rhythm axis, then our alphabetical P through U, and then we'll go finally into the things that sometimes we forget about, which is the blocks, hypertrophies, and even the R-wave progression with voltage. You'll see that I pretty much put every single variation that you could ever find on the internet of the PQRST. I try not to duplicate things, but yeah. So let's go over to the rate. Let me close the slide. Okay. So this will be page 3 of the handout. This is where we're going to start using the handouts if you guys want to follow along. For the most part, I highlighted the bottom of that QT or EKG because this one that I found as a sample didn't have the rhythm strip at the bottom. For the most part, though, use a rhythm strip to help you. It's the easiest way to determine the 3, 150, 170, method, which is honestly the one that I use. And we know that 6 to 100 is normal. Tachy is greater than 100 and less than 60 is going to be bradycardic. So in this, with the rate, I think I have an animation here. Oh, let me see if it does it. Oh, it's not going to. Okay, there we go. So you'd try and find an R that's going to be right on the major darkened line for a big box. And then you're just going to count out 3, 150, 175. And then if it's anywhere between like it is on here, then you can kind of guesstimate for the most part. So that's very simple. That's it. That's the rate. And then if you're going to do rhythm, same thing, page 3, you're trying to decide first, is it sinus? Is there 1 P before every 1 QRS? This is just to ensure that it's not a junctional rhythm or even like a 3rd degree AV block. You want to make sure those P waves are upright because again, it could be somewhat negative in a junctional rhythm because that activity is being generated by the ventricles themselves in the bundles. So 1, 2, AVF, and V2 through 6 are typically where we see the P waves being upright, but for the most part, people will use lead 2 and 1 as their determinations. But we expect that at AVR, it's going to be negative because if you remember, oh, there goes. Sorry. If you remember on AVR, that if that was on the right side of the body, the arm, then the electrical activity should be going away from it anyways. So that'd be appropriately negative. This is also something important is the QRS narrow because you can see, with widened, as we talk about wide complex tachycardias, is it going to be like a ventricular rhythm or not? And then this is where you'll be able to decide is it a normal sinus, is it a fib, is there a block going on, depending on if it's like a 3rd degree where there's not 1 P for every QRS. And then you can also help determine if this is sinus tach and Brady. So when we're looking at rhythms here, you can see there's a P, a QRS, P, QRS, P, QRS, T. So it's clearly that was a normal rhythm because we saw 1 for each. I'm not going to get into the multifocal atrial tachycardias where you might see like 3 different appearances. I think I might get to that later in this presentation. So now we've gone through rate, rhythm. Let's go into axis. Let me see. Okay, so we're at 12:30. So what is the axis? It's the vector that's generated based on both atrial and ventricular depolarization. Let me just move some things out of the way. With ventricular repolarization. So the easiest way, as I mentioned earlier, is you can use 1 in AVF for the most part, but we're going to go the in-depth way so you know multiple methods to generate this. So when your 1 in AVF potentially fail on you because one of them's isoelectric, you know what your backup is. The normal axis would be for in 1 in AVF for both of them to be upright, meaning it's a positive deflection. If it's left axis deviation, you expect that in lead 1, it's going to be upright, whereas it's down in 2 or even AVF. And then right axis, it'd be down in 1 and then upright in AVF. Indeterminate means it's down in 1 and in AVF, which is not very common for us to see. It's nice I just got a spam text in the middle of my presentation. Even easier if the leads 1 and 2 are positive, then it's pretty much normal axis. So let's go through each one of these. And again, I highlighted it down here. You can see that these are the 2 leads for the most part that we're looking at. So let's go a little more in depth. We know that lead 1 right here is going to be at 0. Lead 2 is at positive 60. Lead 3 is at positive 120. And AVL is going to be at negative 30. So let's go, again, more in depth. We're going to go through each one of these pictures specifically. So if we correlate everything we've been talking about up to this point, we'll see that when we have someone that's a normal axis, they can be anywhere between negative 30, which would be a positive in AVL, all the way down to a positive 90 in AVF, okay? So negative 30 to positive 90. Once you get into this blue range, that's going to be right axis deviation. The yellow range is going to be negative 30 to 90, which is going to be left axis deviation. Again, right axis deviation here. And then this would be your northwest or extreme axis, the area that I didn't highlight. So if we look at, if we were to put Einthoven's triangle overall, again, you can look at this image and see that this was a very odd shaped looking heart that they drew in the middle. That lead 3 should be positive at positive 30 or so. Lead 2 is going to be somewhat positive. The axis is down here at 150. 1 would be kind of an isoelectric, right around at exactly at 0. And then AVL is going to be a negative 30. This kind of can be confusing, but believe me, I have other slides coming up that's going to hopefully put it all together. So if we were to look at this, we can highlight this. Remember, look at lead 1. And we see that this is a negative deflection or a positive deflection.
Positive.
Yep, positive. And then if we look at AVF, we see that this is a positive deflection. So both leads are upright. So you're going to get the, I think this is the Fonzie sign. Did I put Fonzie? Yep, put the Fonzie sign. So you get the thumbs up on both. I did recycle that from last year's. Now, if we looked at here, we should see again, let's kind of put it together in a different way of looking at it. In lead 1, it's positive. AVF, it's positive. So that means the electrical activity is going from bottom right to bottom left. So 1, it makes sense for it to be positive. And in AVF, it's somewhat still coming to it. So it should be positive as well. So here's 1. And then we highlight it so you can draw a line for AVL or even lead 1. And then AVF, we see that it's positive. So we have a line going towards AVF. So it was in that block, which would be a normal axis deviation. There is an error. I should have put the blue line down here. So sorry. Now, what if we looked at left axis deviation? It can be a normal variant. So just because someone has left axis deviation doesn't mean they're going to have LVH or even a left bundle branch block, because it can be normal variants. We do see this commonly in African Americans, which I'll bring up at the very end of the slide. I think it's one of the last few slides. So probably in the 3rd section of this PowerPoint. But if you look at the QRS and the generation, we can see that lead 1 is positive. So our arrow is going to go to the right on lead 1. And then AVF, it's negative. So we draw an arrow in the opposite direction. So it's going to be somewhere between this area, right? But I mentioned that if it's between 0 and -30, it could theoretically be a normal axis. So how are we going to know that it's away from that -30? Well, we can use the AVR to potentially help us, because if it's more towards AVR, like in a positive, then that means that arrow is going to be kind of drawn more to the left. Or if it's not really towards AVL, so AVL is positive, so it's actually more towards it. So I'd say that this could somewhat be an appearance for a normal axis deviation. So you can see how you can use these other leads to help you. And even in lead 2, we can see that it's clearly negative. So if we were to draw an opposite line from lead 2, that pushes us more towards a left axis deviation. Hopefully that kind of makes sense, how you can use all these different leads based on your understanding of where the leads are on Einthoven's triangle and on the body of the person themselves to decide if something appears to be between 0 and negative and 120, I should say 0 and -90, and you don't know for sure if it happens to fall between the 0 and -30, do you think this is going to be a left axis deviation? Also know that on the EKGs, as was brought up during our rounds, a few weeks ago and even last week, so the EKG will give you the axis. It'll give you like the number, which is the degrees that it's telling you. I don't want you to get used to just going off that. I want you to understand how to draw this out, to understand it conceptually, and then you can use that number to confirm your finding. So let's look at this one. So what do you guys think this looks like? Normal axis, right axis, or left axis? Yeah, it looks like it's left axis, right? Because we have 1 going positive, we have AVF going down, so they're leaving each other. Left axis, L, starts with the letter L, so left, or L also starts with the word for leaving. So if we were to draw this out, though, we can see that 1's positive. So we're going to draw, I kept putting the arrow on the AVL, I apologize, but it wouldn't affect it in this one. AVF, it's down. So instead of drawing an arrow down towards AVF, we're going to do the opposite because there's an overall negative deflection. It was going away from AVF. So then we know that this is going to potentially fall between this area. If you want to be absolutely particular, you could see, well, so let's see, lead 2, it's somewhat isoelectric. So that would put us right at 45 degrees, or actually right around 30, I should say, because of 60. So you could use maybe even lead 3 to help you, and lead 3 is negative. So then it would put it more towards -45 or so. So that would have confirmed our suspicion that this is a left axis deviation. So again, -30 to -90 is the definition for left axis deviation. But again, be aware of this 3-axis method, however, because as I mentioned, when lead 1's positive, you don't know that it's not in that -30 to 0 region. And then as a result, we can use lead 2 because using only lead 1 and AVF cannot completely rule out that it doesn't fall between the 0 and -30. But and in here, not necessarily in this one, but if lead 2 is positive, then it's likely going to be a normal axis deviation. So in here we have normal or +1, negative AVF, and then in lead 2, it looks like honestly that it's mostly negative, to be honest with you. So I would kind of push it more towards the left axis region. All right, here's another one. Already tells you the answer, so I'm not going to ask you guys. Clearly, there's a +1 or deflection in 1. There's a negative deflection in AVF, so this looks like it's a negative axis deviation, leaving each other. Another left axis deviation, we can see +1, negative AVF. All right, so we finished left axis deviation. I talked about, it's going to be the exact same for the rest of these axes, these ideas of using multiple other leads to help you. But just know that with left axis deviation in particular, you have that area that you have to be able to account for, which is that 0 to -30, that could still be considered normal axis, which is why you're going to use potentially lead 3 to help you, because if lead 3 is purely negative, then that means it's going to be the opposite. So it's going to push you more towards a left axis direction. Whereas maybe if you used maybe AVR, for example, and AVR was negative, then it's going to push you down towards +30. So it's going to get you more likely towards a normal axis region. What questions do you guys have before I go into right axis deviation? None. Okay, good. So our axis deviations, just like the left axis, could be a normal variant. You can see the same exact things as I mentioned, right bundle branch, RVH. Dextrocardia, very unlikely for us to be seeing that in our patients. I've only seen it twice before. Left anterior fascicular block can be seen with left axis deviations, and left posterior can be seen with right axis deviations. You don't really have to memorize that. You just be aware that they exist in all honesty. So let me go to this slide at the bottom, or refer to this. So if we mentioned that positive deflection 1 with a negative deflection AVF was a left axis deviation, then the opposite holds true for a right axis deviation. It would be a negative deflection in 1 and a positive deflection in AVF. So they're going or returning towards each other, which would be suggestive of a right axis deviation. If you want to be absolutely particular, as we're going to for this section, you would say that let's look at AVF. It looks like it's overall positive, so we're going to draw an arrow down to AVF. And then we can see that in in lead 1, it's going to be overall negative. So instead of drawing an arrow towards 1, we're drawing in an opposite direction. So that means the overall deflection has to be towards the bottom left direction, which would be a right axis region. So let's highlight lead 1. I kind of got it cut off there. I apologize. Was a negative deflection, and there was a positive deflection in AVF. So one's going down, one's going up. So they're returning to each other, which would be a right axis deviation. And then if I were to draw the arrows out to show you, we see that the arrow going down in lead 1 means that instead of drawing your arrow out towards 1, you're going to do it in the opposite direction. And then if you were to draw the arrow for AVF, it's a positive. So we draw it towards AVF. That means the region of involvement of this electrical activity has to be towards here. What does that mean? Well, we see the SA nodes up here towards the 120 region, and then the AV nodes kind of right towards the lead 2. So instead of truly going towards lead 2, it's going more down. So there's some pathology that occurred on the right side of the heart, whether it's RVH, the left posterior fascicular block, like I talked about. If you have a left posterior fascicular block, then maybe it's having to go around it. Or if you have a right bundle branch block where there's ischemia on the right side, so then the activity goes to the left side preferentially, and then it eventually is going to get to that right side, then you can see the electrical activity is going to kind of go towards it. So then we can highlight that region and see that it's a right axis deviation. Just to make sure, if lead 2 is normal, then axis will always be, if leads 1 and 2. So if leads 1 and 2 are always normal, then it has to be, for the most part, a normal axis, not just because lead 1 is normal. So right axis deviation, we can see that on lead 1, it's going to be a negative, and lead AVF, it's positive. They're returning to each other, so it's a right axis. I put a knowledge check, but I didn't actually put any knowledge to check you guys on, so disregard that slide. I've been working on this throughout, and I think I just completely forgot to come back to it. I blame you guys, because usually when I'm working on this, it's during like clinic, and then there'll be a patient that you've seemed to have to staff with me, and then it gets me off. So, all right. So let's look at lead 1. We see that this is positive. So we're having that arrow go towards lead 1. If AVF is positive, it's going down towards it. So that means it's going to involve that right region, that bottom right. So it has to be normal. Let's take a look at this one. If AV1, so again, lead 1 was positive, AVF was positive. So both are upright. So those are a normal axis. But if lead 1 was going down, which would cause the arrow to, well, I screwed up the animations on that. It was negative. So again, this yellow arrow is not going to lead 1. It's going in the opposite direction. AVF was positive, so it is going towards AVF. That means the halfway point between these two would be lead 3, which would be a right axis. We would expect that in this one. So AVL, it would make sense for AVL to be negative, right? Because that, if it wasn't, that would be completely off of everything I just told you guys. But we can see that AVL here is clearly negative. So instead of drawing the arrow towards AVL, you're doing it in the opposite direction, which confirms our findings with what we saw in lead 3. Oh, I just realized you guys are answering the questions. I apologize. I've just been going straight through them. All right. Lead 1, see that's positive. I think this one I did the arrows correctly. And then lead AVF is negative. So what do you guys think this is? Okay, so people are saying LAD. So then we use lead 2. It looks like it's somewhat isoelectric, which is not really helping us. But, if we were to say that it's isoelectric, then we're going to do a perpendicular straight on. But then we know that we could use let's see, we could use so we used AVF, maybe we could use lead 2, because if it was opposite of lead 2, then it would push us more towards the left side. But I just told you that it was kind of isoelectric. So what about AVR? AVR is negative. So instead of going out, it's actually going to be more a physiologic LAD. So it's going to be right in this region. Okay, so you guys were correct, LAD. This is from EKG Wave Maven. It's a great site if you guys, and I'll have it at the very end of my eventual symposium. It seems like it's going to be on EKGs. I'll reference slides. I think it's very good for you guys to not only test yourself, but if you want to get EKGs to be able to create your own archive. And Dr. Duffy has a great book as well from Mayo Clinic that he uses for sample EKGs. You can use them. So in this one, we can see the lead 1 was positive. So we're going towards lead 1. AVF was negative. So we're going away from it. So we're kind of going between that 0 to 90. And lead 2 was negative. So we're going to go away from lead 2. And it's going to be more towards the left axis deviation. So we can see that it pushed us to, again, the left axis region. If lead 1 was positive, then it would push us more into the normal axis region. All right, so we've gone through rate, rhythm, and axis. What questions do you guys have before I start into the PQRS? Oh, man, I'm not ice melted on this. No questions. Awesome. Okay. P waves. So this is where I will, I'll probably start asking questions, or I might call out in certain people for this part. So page 7, your handout, the bottom right, you can see where we are in the PQRS axis. It's going to be the first positive deflection after the previous T wave that you have. Again, it's that atrial depolarization. It should be less than 3 small boxes. 0.12 is theoretically the duration of how long your P wave would be. Anything prolonged, you might consider right or left axis or atrial enlargement. What kind of patients would we expect to see or might we see with left atrial enlargement? Yep, mitral stenosis, athletes, absolutely. You can see it, with our patients with atrial fibrillation, right? Sinus rhythm, it should be positive in the limb leads. If 1 or 2 of those leads have a negative P wave, then there's something wrong likely with that electrode placement. Yep, yeah, right, atrial fibrillation, yeah. So in this situation, this would be one where it's like a limb lead reversal. You can see the P waves are completely inverted. This does not have a junctional type appearance to it either, or else you could say, oh, this is a junctional rhythm, and we'll get to junctional rhythms later. I don't want to kind of jump ahead of myself. But you can see that with the P waves being inverted in here, you're starting to suspect that this is a limb lead reversal. What is, again, the P wave represent? It's the depolarization of the left and right atria together. Theoretically, those two together are going to create this single hump. But if you have unilateral, or I should say asymmetric enlargement of either the right atrium, which may occur with prolonged pulmonary hypertrophy, or P mitrale, yep, that's that appearance that looks like a little M, or with the left atrium occurring with like mitral stenosis, as mentioned by you guys, you can see this start to split out and start to have a different appearance. Again, think threes, 3 small boxes long and about 3 small boxes large is what we expect as the normal for this. It should be positive in lead 1 and 2, which makes sense, right? Because the electrical activity as drawn out by this green arrow is going towards it. So it should be positive. And it should be negative in AVR because AVR is going in the complete opposite direction. So when you don't see that, if you see a negative or an inverted P wave in 1, or you see maybe a positive AVR, something's completely wrong. Or it could be dextrocardia, right? Oh, actually, I just put that there, yeah. Lead placement or dextrocardia. So when you see 2 waves, what I mean by that is instead of it just being one single hump, but maybe you see 2 humps like the P mitrale or the P pulmonale with this, sinusoidal wave or the biphasic wave. Yep, Miriam. Then you're suspecting that there's some other pathology going on with the atria. It's normal to see biphasic though in V1. So this sinusoidal appearance can occur due to separation you might see between the right and atrium when they're depolarized. Because remember, they're not always occurring particularly or exactly together, especially if they have increased pulmonary pressures, which can then affect that. So just know that you can sometimes see it as a normal variant, but if you see it, you should start looking, I'd say, for pathology that might already exist in that patient, or maybe you're going to diagnose something. So let's look at what would the appearance of left atrial enlargement look like. It would look like this P mitrale appearance. mitral valve, left side. That's one way that you can remember yourself for that. But just know that it's only going to be in leads one or lead two. The lead V1 would have more of the sinusoidal appearance. So valvular diseases, as was mentioned, mitral stenosis, atrial stenosis can cause left atrial enlargement. We can even see it with LVH or HOCM, maybe as a byproduct of it. This is, again, called P mitrale. So you can put that letter M inside that appearance of that wave, and it will make it look like an M for P mitrale. Remember, in V1, it's going to have the sinusoidal appearance. This is something that I personally didn't even remember. I was like, oh, okay, that's a really good thing to know, because I can see how if we just jump to this being, oh, this must be P pulmonale, which I'll get to what P pulmonale looks like, you might make the exact opposite diagnosis or look for the diagnosis in the wrong area of the heart. And again, you can use the threes rule, but for the most part, it's going to, this depression that you're going to see in V1 is going to be at least one block large and wide. So let's see. I think I didn't mean for that M to kind of show up there. So if we were to look at lead V2, I mentioned lead V1, or lead 1 and leads 2 are going to be really helpful for us to look at the P waves. We can use even AVR because we expect it to be negative based on the axis diagrams that I showed you. But if I were to zoom in on this area, you can see how it's at least one box, small box large, and one small box tall. And it has that M appearance for the P mitrale, whereas in V1, I don't think I zoomed in on that, but if you kind of look, you can see that it has that sinusoidal appearance. If the second part of the biphasic rule is bigger, you mean it's left atrial enlargement? Yes. So that second part, so the second region in this area that I didn't zoom in on V1, it would be suggestive that this could be left atrial enlargement. But you can also see with the M appearance, the P mitrale, that can also be suggestive that this is a left atrium. So if you see just V1, this sinusoidal biphasic appearance, or around here, sinusoidal appearance, if you don't see anything in V1 or lead 1 or 2, I probably wouldn't just automatically call it left atrial enlargement. You should see it in both. Yeah, I screwed up the changing of the color for that, so I apologize. So if we look here, this is where I enlarged V1. You can look in and you can see how it has this sinusoidal appearance, not the biphasic, which we would expect in lead 2, but the sinusoidal appearance, which is going to be one box wide, one box deep. So you see that in combination with pathology in lead 1 here, that's going to be more, or leads 2, you're going to be suggestive of more of a left atrial pathology. So let's look at leads 3. You can see here in lead 3, also it had more of a biphasic appearance. The right axis and then the left axis. So the left axis is that second portion of depolarization. And we saw that that's larger. So it's more suggestive that this is going to be the left atrium being involved. And then if we were to look at V1, I don't think I zoomed in on it, but if we were to look at V1, you would see that it has that sinusoidal appearance as well. So brief review, again, left atrial enlargement. We can see it with mitral stenosis. You can see it with atrial fibrillation as well, whether it's a byproduct of the mitral stenosis. We're going to look at V1, leads 2, leads 3, and we're going to use, and even leads 2, 3, and then V1. And V1, we're expecting to see that sinusoidal appearance, and leads 2 and 3, and even lead 1, you can see that biphasic appearance with the second wave of the biphasic region, as Miriam mentioned, being more suggestive of left atrial enlargement, because that first region is going to be when they're split, right atrial depolarization, and then the second portion is going to be left atrial depolarization. So now we're at 12:53. So I'll finish up on right atrial enlargement, and then we'll kind of call it from there, because I think that's going to be a good block to stop at. That's called the P pulmonale, which makes sense because the pulmonic valve on that right region kind of fits. We can see that it's going to be greater than 2.5 to either 1.5 of enlargement in terms of the duration, I should say, the inferior leads and V1 and 2 respectively. While left atrial enlargement was more suggestive of mitral stenosis, we'd see that right atrial enlargement would mean that it's more suggestive of tricuspid stenosis. You can still see that with our patients that have disease, but maybe if it was like an IV drug user and they had left or tricuspid valve enlargement, that could lead to damage with stenosis and regurg. You can see with pulmonary hypertension, COPDs, and even tetralogy of Fallot. As was mentioned by Bobby's talk last week when we were talking about congenital heart diseases. For the most part, congenital heart diseases aren't a large portion of your boards. The times they're going to bring up is when it comes to endocarditis prophylaxis and murmurs. I do have a board review cardiology PowerPoint that I've made for you guys. I try to go through everything that you'll need to know for the cardiology section of your boards. I just have to find a time that I can go over it. I think I probably will do it somewhere in the middle of the next block, just to give you some time to review information and test your own knowledge. But to go back to what I'm talking about, again, we're going to look at leads 1, 2, and then even V1. In V1, in the previous slide, we saw that it had the sinusoidal appearance, whereas V1 for the left atrial enlargement. Whereas for right atrial enlargement, we're going to see it's going to have more of a positive deflection, still somewhat of sinusoidal, but it's clearly not going to be equal. It's going to be predominantly going to be a positive deflection. And then in lead 2, where we had that P mitrale type appearance, we're not going to see that as much. Again, we're going to see, ooh, that's not good for the computer. Alamon just destroyed a computer that is going to be the future program director's computer. So you guys can make fun of her when you see her. That's definitely going to break you. Okay. And then for the right atrial enlargement, it makes sense that if I said that the first portion of lead 2 was the right side and then the left side was the second portion, that if we're thinking about right atrial enlargement, then we should see it predominantly be positive on that first deflection. Just again, as we mentioned, the second deflection was positive predominantly for left atrial enlargement. So for right atrial enlargement on the P wave, you can see that I completely screwed up that. Wow, this came out bad. I'm sorry. It's not my standard. I have not met my own standard for what I expect for my own EKG or PowerPoints. But in this one, you can see that here we have somewhat, it's hard to tell if this P wave encompassed part of the previous T wave as well. But if it did, you can see that the second portion of the P wave or even the enlargement of itself is very enlarged in comparison to the QRS complex. I don't have the calibration box, but we would assume that the calibration box is 2 large boxes. In an atrial pace rhythm, oh, I thought I had boxes here, but I didn't. You can see that when you have these long, perfectly perpendicular spikes, it's suggestive of an atrial pace rhythm. I just put that in there so you guys know, just to be complete, because I didn't think that I had a second or a separate PowerPoint just going over pace rhythms. I did talk about it with our last talk on cardiology procedures, just knowing how to identify if it's a pacemaker versus an ICD, and I think it was brought up on my chest x-ray talk as well. But obviously just look for those the exact deflections, which will then lead to a P wave that sometimes can be inverted. Whereas if there was a perfectly perpendicular deflection on the QRS, that's going to be a V-paced pacemaker. And here, this is very, very subtle, but you can still see it on V1 and even AVR. You can see that there are these pacemaker spikes there. Very, very subtle. It might help to have maybe a chest x-ray in that patient if you didn't know that they had a pacemaker, or if maybe you had some concerns about what that was that you were seeing. And maybe pacemaker spikes didn't come into your thought process. So, and remember, you can use the chest x-rays to help you. So I'm going to stop there because I think that's a good place. We're at 12:57. I'm at slide, I don't know, actually. I'll figure out what slide I'm at. I think my plan is for this to be 3 sections. So we'll go into the intervals as the next part of this. And then after intervals, then I'm going to go into LVHs and then the bundle branches and then the QRS complexes particularly. Then there's a large section just on ST depressions and elevations and how they can change with time based on the progression of an infarction. And then I'll get into the common EKG patterns that you should see, whether it's Wolff-Parkinson, AFib, VFib, VTAC, et cetera. And then we'll finish off with benign findings with African Americans. So, and this was not, the whole part of this talk is to be a very all-encompassing view of an approach to EKGs. I think the next section of EKGs, I don't even have my own schedule up, is probably gonna be later this week. And then I'll find a time that I can do the 3rd section. And then I will have, I've already put myself on for the second part of the cardiology talk for the procedures. I didn't forget about that. So we will be finishing that up. And then I will have a cardiology board review PowerPoint, which is about 180 slides that goes through each section based on ABIM of the information you guys need to know before we kind of wrap up the cardiology section. Questions you guys have before I end the talk? Was it helpful to see kind of the understanding, the physiology, the anatomy, and how to approach, I spent a lot of time on the EKG or the axis specifically, but hopefully you guys found that beneficial. It might have been not over your head, but like easy for a lot of you. But again, I'm not going to assume we all are at the same level. So, okay, awesome. Thank you. If you guys have any other feedback, let me know. I know for our medical student, Dr. Swanberg, you had asked about a talk on thrombocytopenia. So that will be the plan for this Friday, unless there's something else scheduled. But I'll be doing a rundown on thrombocytopenia on Friday after your MixApp quiz. All right. Thank you all for paying attention. Appreciate it.